which then progress from eyes to chest and abdomen in next 20 days. She also noticed child passing clay-colored stool since 1 month and dark color urine since 1 month of age. There was no vaccine and weaning of jaundice. There was no associated temperature instability, excessive cry, or refusal to feed in the child. There was no history of vomiting, loose stool, or constipation in child. No history of fever, respiratory distress, or any rash in the children. No history of seizures or hearing loss. No history of NICU admission or any bleeding from any side. Umbilical fall around 10th day of the birth, according to mother. Child was third. The child is third in order, born from non-consanguineous marriage of parents. No similar complaint in mother or father and other family relative is seen. There are two elder siblings with no history of similar disease. Child was from spontaneous onset of labor, normal vaginal delivery done in a government hospital. Birth weight was around 2.5 kgs. There was no major congenital anomaly noticed at the time of birth. Child cried immediately after birth and passed meconium within 24 hours of birth. There is no history of admission in NICU during birth or after birth. Coming to the antenatal history, patient was an unbooked case. No antenatal scan was done. Mother took iron folic acid tablet from Anganwadi workers. Mother didn't have a history of fever with rash, diabetes, or hypothyroidism. There is also no history of drug intake for any major illness in mother. Child has attained milestone appropriately as per age, such as social smile. Child makes sound other than cry, grabs clothes, moves both arms and legs, holds head when on tummy. These are in accordance to the developmental milestones, which comes under 2 to 3 months. Normal child takes normal intake of breast milk and formula milk. History of bottle feed is present. Child is immunized as per age. Last vaccination was done at 2.5 months of age.
Okay. So you finished history.
Yes, sir.
Okay. So then can you summarize your history?
So general
All the
examination
salient points,
left,
summarize the history. Yeah, go ahead.
sir, general examination is left, sir. Can I continue?
No. You summarize the history so that we
Okay,
have
sir.
a recap of what you said. Summary of your history.
Okay, sir. 3-month male baby, born normal vaginal delivery, presented with chief complaints of yellow discoloration of eyes and skin since 14 day of life, with complaint of passage of dark colored urine and clay colored stool since 1 month of age.
Okay. What else? What are the important negative histories? You have taken so many negative histories. So what are the pertinent negative histories?
So
Don't
first is
repeat everything. What are the
no,
important ones you said?
yes, sir. There is no history of fever and rash in children, no history of NICU admission, no history of bleeding from any side.
Okay. NICU admission implies what?
So NICU admission implies child was in sepsis, is in sepsis, then he may require a NICU admission. That's why, sir.
Okay, okay. Rash,
Sir, rash will go towards a congenital torch test in which there is a herpes simplex. That's why there is no history of rash.
oh, rash can be in so many other things also.
Cytomegalovirus, herpes simplex.
Okay, a variety of things. Right.
Yes.
Bleeding,
Sir, bleeding can be bleeding is a sign of, sir, fulminant hepatic failure. That's why, sir.
okay, even in synthetic deficiencies also you can have bleeding, ecchymosis,
Yes, sir.
etc. Why only
Raised UTI and
fulminant hepatic failure?
yes, sir.
Yeah. Respiratory distress, what were you hinting at?
Yes,
Fever,
sir.
respiratory distress.
So respiratory distress goes under the same, sir, sepsis.
Okay, something else, some other things also can have respiratory symptoms in a child with jaundice. Some other,
Sir, any hemolytic anemia or blood transfusion or polycythemia, volume overload.
okay. Okay, cystic fibrosis, complex, which we know can be also associated. Okay. Although it is uncommon in our country, in the Asians, it is still possible. Right. So there was, what was the significance of that umbilicus falling? I didn't get it.
Sir,
Why did you single that out?
if umbilical cord persists beyond, say around, it falls around 7 to 10 days or 7 to 15 days. If it persists, after that, this can lead to, sir, bacterial infection, and that can lead to umbilical sepsis and sepsis in the child. That's why, sir.
Okay, so that is why you asked. Do you know
Yeah.
per se any condition where there is typically a delayed fall of umbilicus? In neonatology, they are very careful about that. Do you know of any disorders, any immune disorders? Okay,
No, sir.
that is homework. Fine.
Okay.
That is homework. You all will find out about which immune disorders you have a delayed fall of umbilicus. Right. Then you mentioned about there is no waxing or waning.
Yes, sir.
So basically it implies waxing and waning.
The vaccine of waning means that child jaundice is not improving in the child, sir.
If there is a history of waxing and waning, what would you consider, and how would it impact your management?
Sir, if it's vaccine and waning is there, sir, then it can be a physiological jaundice.
Does physiological jaundice go up and down?
Sir,
It goes once up, then remains, and then it comes down forever. It doesn't go up again.
That is why I also
very
asked.
important, no? Persistent jaundice, persistent clay-colored stool, or a waxing and waning. Extremely important history.
Sir, it will lead to extrahepatic. It may lead to an extrahepatic cause of jaundice.
Yeah, if there is it's a simple question, so don't get foxed by simple questions. All questions are not going to be difficult. So examiner asks very simple questions generally. So waxing and waning, increase and decrease means that it is a hepatitic process, because
yes,
everywhere we are trying to separate medical jaundice from surgical jaundice. So
yes.
waxing and waning is generally a hepatitic process. Have an obstructive jaundice like the biliary atresia, the common thing which we want to narrow down to, that is a progressive jaundice, and that is persistent clay-colored stool.
Yes,
and
sir.
how does it affect your management? If it is a persistent stool, you are not going to waste time at all doing anything. You will very quickly go on to establishing the diagnosis, cholangiogram, and proceed. Whereas if you
Yes,
have a waxing and waning, you might spend some more time, think about other investigation, biopsy, etc., etc. So it's therapeutically also it makes a difference. If you say this, then the examiner knows that you are aware of these things. Okay. Go ahead. Go ahead. Anything else?
Hello, Gaurav.
Yes, sir.
So
Yeah.
classical vaccine weaning, sir has very nicely said. But again, in an older child, it will be CVD is also one of the very important reasons for vaccine weaning. At 2-month-old child, again, sir said the correct reason.
Okay,
Why did
sir.
you ask about rashes? Rashes. Do you think the rash in the child is going to happen in a child of biliary atresia? Or
Sir,
is
it
it the
can
rash
happen
history in the mother?
Sir, it can happen in a child of biliary atresia, sir. If there is herpes simplex disease in child, in
So you
mother,
think
it
that
can-
the herpes simplex happened in the child and then it led to biliary atresia? Do you think it's an antenatal process or it's a postnatal process?
sir, basically, sir,
Torch of mother or torch infection of child?
trot infection of child. Sorry, mother, sir.
So remember that. So child, when most of the situations will not have rashes.
Hello.
Please go on. Go on, go
Okay,
on.
go ahead. Go ahead. So what do you think at the end of your history? What do you think this child has? What is your differential?
Sir, my provisional diagnosis is 3-month-old male with infantile obstructive cholangiopathy, most probably secondary to biliary atresia with or without hepatocellular failure.
Why do you think this is biliary atresia? Why not the other group of medical causes? One of them. Why, from your history, do you think this is biliary atresia? What is there in your history to say that this is biliary atresia?
First off, sir, there is first off is child is presenting after 2 months and there is elevation of direct bilirubin.
No. We are not going into investigation. From your history, it's a 3-month-old child, a male, a normal vaginal delivery, and there is hardly any other history. So why are you thinking that this is likely to be biliary atresia?
Sir, due to the presence of dark colored urine and clay colored stool.
Yeah, you said there is no, it's a persistent jaundice. No, it's not a fluctuating jaundice.
Yes, sir.
So you can say only what from the points that you have.
Yes,
So that is probably there. And there are no other features to point towards a hepatic process
sir. Hepatitic cause of the
or an
jaundice.
etiology. So that is why probably it can be. You cannot be so sure, but you can say most probably it could be that rather than a hepatic process. If you
Yes.
had other features, a sick child, etc., then you would think towards a hepatic process.
Yes, sir.
Right. Okay. So you think it is that. What are these common forms of neonatal hepatitis that may mimic biliary atresia very closely? One or two of them which mimic biliary atresia very closely. They will also have a well-preserved child. They will also have persistent jaundice and pale-colored stools, not fluctuating jaundice. Do you know any one or two?
Sir, Aspergill's syndrome.
Alagille syndrome, you're saying?
Yes, sir. Sorry, Alagille syndrome.
Okay. Okay. What else? Something else?
Polydactyl cyst.
Polydactyl cyst. That is a different thing. I'm talking about the metabolic causes and those hepatic causes.
Okay, sir. And then we can go to some Rotor syndrome.
Okay. Some of the this alpha-1 antitrypsin
Alpha-1
deficiency.
antitrypsin deficiency.
Some of the PFIC can also have this picture. But
Yes,
it
sir.
is there, some of them are not common in India. Alpha-1 antitrypsin is not common. So that is why we really don't get them, but they can mimic biliary atresia very closely, very, very closely.
Yes.
Okay, go ahead. Go ahead. Go ahead to examination.
Baby is alert, conscious, and active with normal feces. Weight is 5.2 kg. Length 62 centimeter, which is more than 25 percentile. Head circumference is 43 centimeter, which is more than 15 percentile. Pallor and icterus is present. No obvious cyanosis, lymphadenopathy, or rashes. No bleeding spots or a spider angioma visible on body. BP is 92/63 mm Sg in right arm supine position. Pulse is 106 meter, regular, good volume, taken in right hand. Respiratory rate is 30 minutes. Thoraco-abdominal temperature is normothermic.
Yes.
In systemic examination, coming to CNS examination, patient is conscious, alert, active, moves all four limbs actively, moves head and eye in response to sound, coordinated suck and swallow present. In a spine examination, there is no scar mark, no mass seen, curvature is normal, no tenderness. In respiratory system, chest is symmetrical in shape, no dilated veins or scar seen. Bilateral air entry is equal, no added sound heard. In CVS examination, S1, S2 heard with no murmur. Abdominal examination. On inspection, abdomen is distended, umbilicus is centrally placed, no dilated veins, no with scar mark present, yellow discoloration of abdominal skin is seen. On palpation, skin temperature is normal, no tenderness elicited on palpation. Liver span is 5 centimeter, 7 centimeter, smooth round edges, firm in consistency, no nodularity, spleen is not palpable, liver is palpable 3 centimeter below costal margin, there is no ascites. On percussion, dull note is heard in right hypochondrium region, tympanic note over rest of the abdomen, shifting dullness and fluid release absent. On auscultation, peristaltic sound is heard. Hernial sites are normal. A colic stool is visible in diaper. That's why I didn't did any PR examination. On genital examination, a scrotum is normal, bilateral testis is descended, penis is normal.
Okay, go back to your examination slides, the first one.
Yes, sir.
Okay, right. General examination. So normal faces. So you were trying to see whether there are features of some syndromes,
Yes, sir.
right? So what are the different syndromes which may commonly manifest as jaundice, infantile jaundice? Some common ones.
Byler's syndrome, Byler's disease.
See, when you are asked about common ones, you say the real common ones. What about hypothyroidism?
Yes, sir.
So why are you not telling the common things? Always common things score, and they'll score for you, marks also.
Okay,
So
sir.
hypothyroidism. Another one amongst the syndromes in cholestatic disease, which is commoner than the other things.
The polyasplenia.
But do they have some faces? BASM, you're talking about BASM. Do they have some faces?
Which is Down syndrome.
See, someone has mentioned allegedly.
Allegedly syndrome, sir.
Okay, so the common ones you should say first. There are so many uncommon ones, but the
Yes, sir.
common ones you should say first. There is hypopituitarism. There are so many other uncommon ones also. Right. Fine. Then the other thing is, temperature, all this you have written, icterus. Okay, go on to your next thing. Spider angioma. Do we get spider angiomas in a 2-month-old, 3-month-old child?
Sir, it will
Ecchymosis, I can understand.
sir, it will be seen if there is progressive liver failure, then only, sir.
Yeah, but we are talking about a 2-month, 3-month child, no? So what I have never seen one in a 2-month, 3-month one. It's very uncommon. So when you translate things from directly from adult medicine, be careful.
Okay, sir.
Okay, right. Go on to the next slide. Why have you concentrated on spine? No scar, no mass, curvature normal. Why spine? So much about spine.
Sir, in Agili syndrome,
Ah,
there is butterfly type of vertebra. That's why, sir.
but can you make that out on clinical examination? You know what a butterfly vertebra is? No, I knew you will say that. So what is a butterfly vertebra? So a butterfly vertebra is a hemivertebra,
Hemivertebra.
right? And it need not be many segments also. It might be just one segment. So it may not produce your your scoliosis, etc., etc. And externally there might not be anything. That is why we do a radiograph to see that. So that is not a very important physical sign which is obvious, right? Okay. What about the CVS? Some no murmur and all. Why? What murmur were you expecting? Or can you expect or can you get?
Sir,
Obviously related again to the common syndromes. What do you get in allegedly? You were talking about allegedly. What do you get there?
sir, here we get a cardiac anomaly is present, sir.
Yeah, you get pulmonary stenosis. See,
Yes, sir.
when you talk so extensively about allegedly here and there, be ready for them to question you on allegedly. Although it is not something which you see extremely commonly, but then since you mentioned it and you are mentioning about hemivertebra, etc., one odd questions from here and there will come up about allegedly because allegedly is a commoner rather than non-syndromic paucity thing. So they might ask you a question. So that is what you're looking at. Peripheral pulmonary stenosis or those murmurs you're looking at.
Yes, sir.
Okay. Then your abdominal examination is fine. What do you mean by this liver being smooth and rounded edge? What does it mean? Is it normally like that in a child, in a 2-month, 3-month-old child, or is this abnormal?
So it is normal.
Okay, so the normal liver edge which you feel in an infant, 1-month, 2-month, 3-month infant is rounded. So
More
if you
like
say that, they will ask you describe the normal liver. Can it be felt normally in an infant? If so, how does it? What is the surface marking? They will ask you that. So can it normally be felt in a 1-month, 2-month child?
no, sir.
Can't be felt. It can be felt. Just below the costal margin, it can be felt and it goes
So,
across. You can feel it even better in the epigastrium where it crosses the epigastrium and goes to the other side. So you can, when you open abdomens also you have seen, no, the left lobe of the liver
yes,
is
sir.
a little more prominent that side in the epigastrium. So it can be felt. You must know that. And is it firm? Is it, what do you say, smooth, round? Is it rounded edge or does it feel sharp?
So it was smooth and round in edge.
Okay, it is a normal liver has a very fine sharp edge. No, it's almost a leafy edge. It is not rounded. If it is rounded, it means that there is some abnormality there. Okay, so that is another physical finding which you must be familiar with. Normally, it's a very leafy edge, a nice sharp edge that you find. That's a normal liver in an infant, and firm, of course. There's no nodularity you have written. So when you have a rounded edge and all, it means that there is some disease process, something that is happening there. Otherwise, it wouldn't be rounded. Okay, no ascites, you said. And then next slide, something about PR. You made a statement since the stool diaper has acolic stool, I didn't do a PR. Now, what does that mean?
So basically, I was looking for doing a PR to look for the color of the stool, but I saw the color of the stool in the diaper only, so I didn't did a PR examination.
I see. Okay. But that is not the only reason why you do a PR. And anyway, in a child like this, with this sort of a thing, in a small kid, if you may even avoid a PR, but then if there's an abdominal mass, we always want you to do a PR. Here, the history is a little different. The PR
Different.
may not give you any finding, but there is just the ecolic stool visible in diaper, you need not say as a justification. Why I'm saying this is, if you say some unnecessary things which divert the examiner's attention unnecessarily, they will go in a tangent there and question you. That is why. Okay, right. So genital examination is normal according to this. Can it show something, the genital examination, in a child like this who has liver disease? An infant.
Testicular atrophy.
So early, again you are going on adult medicine tangent. No, it doesn't happen. All those
That-
things don't happen in children, in an infant. Hydrocele, someone is saying it can. So these are common things you should say. A hydrocele happening with ascites, because you have patent process of vaginalis. And if you have a preterm baby, all the more reason. You must have seen some children. It
Yes,
looks
sir.
big. Yeah. So common things, always say common things first. Okay, right. So we have gone through your history and gone through your examination findings. Again, nothing very too much in your examination. So just summarize both and then we will go to your differential diagnosis after that. I think Dr. Bagdi is there. Sir, would you like to ask something? Dr. Bagdi?
Any scan was done?
So
Yes,
he is
sir.
not gone to investigation.
No. The history, no?
He
It's
is in
only-
history. History examination. Yes, sir.
Whether antenatal scan was done. And if at all,
No,
what
sir.
do you expect in an antenatal
Uh-huh.
scan? In
Where-
biliary atresia, what do you
Where
expect?
antenatal scans done? Sir is asking where antenatal scans done. Could they
No,
pick
sir.
up
No
biliary
antenatal
atresia?
scan was done, sir.
Okay, can an antenatal scan pick up anything? If at all it's done in, say, big cities, antenatal scans are done routinely nowadays, all anomaly scan and all that. It picks up so many anomaly scan, and antenatal scan pick up biliary atresia.
So that's the question for you. Antenatal diagnosis of biliary atresia. Is it possible? What are the features that may be seen?
No, sir. It can't be. I have not seen like that, sir.
Aren't our
Okay, so that is also homework for you.
MAMC students are not joining.
See, if you see an absent gallbladder in a fetus, okay, though the triangular cord sign may not be seen, but sometimes absent gallbladder should raise a suspicion.
Yes, there's someone else, sir, who's also written there might be a portal cyst in some forms, so cystic biliary
Yeah.
atresia.
Sometimes the choledochal cysts, they also cause of neonatal jaundice. They also are picked up in antenatal scans. So you must mention
Yes.
about that. Okay. Right.
Right. And then there are some reports which say that the same triangular cord sign which we look for later may even be picked up.
Yeah.
But then very few of us have seen such antenatal scan. But remember these things. Okay. Now just quickly summarize your history physical findings and then we will go on to your differential diagnosis.
3-month-old male presenting with chief complaint of yellow discoloration of skin and eyes with passing of clay-colored stool and dark-colored urine and with urine
What happened? We are not able to.
Out. So
Yes,
maybe.
yes. The Gaurav, we lost you.
So there's a power cut in our area, so the Wi-Fi connection is off.
Hello. Sir, I am back, sir. There was just
Yeah.
problem in network, sir.
Yeah. Come back. Yeah, Gaurav, we had lost you.
Yes, sir. I am just
Okay. So what is your differential diagnosis?
So my differential diagnosis is a neonatal hepatitis and intrahepatic biliary hypoplasia.
I thought right from your history, you were saying that this is likely to be biliary atresia, and then your examination changed it, is it? How did it change to neonatal hepatitis now? Why? Why did it change?
Yes, sir.
No. Why has your diagnosis changed? Now you think it is neonatal hepatitis and not biliary atresia. Biliary atresia is lower down. Why? According to you? Why have you taken biliary atresia to the second place? I thought you were telling that that is your first diagnosis earlier.
No, I think he's diagnosed biliary atresia. Differential diagnosis is giving as neonatal hepatitis. That's the way I understand.
Gaurav, are you with us? Hello? Network issue. Okay. Okay, let us ask the others till Gaurav comes back. Why do you think this is neonatal hepatitis? Or would you think it is biliary atresia first? Exam going. Students, please. Ashwin.
Sir, I would like to further evaluate, and then my first differential diagnosis will be biliary atresia.
Okay.
And I would keep a differential diagnosis of neonatal hepatitis also, but I would like to further investigate and confirm my diagnosis, sir.
Okay, so you would like to keep biliary atresia first?
Yes, sir.
Right. Okay. So how do we proceed? Till Gaurav comes back, I think you continue.
Sir, I would like to investigate first with blood investigation, sir.
Right. What would your panel be? Is there any other things before you go on to investigations? Is there anything else in the ward you would like to do? Any other examinations before you go on to investigations, which we do routinely? Evaluations. Common things. Yes.
Fundus exam.
Fundus. Someone has written fundoscopy. Isn't it? So quickly, can you tell me what are the different surprises that might come up in the fundus findings, which might help in the differential diagnosis of infantile cholestasis?
Sir, a congenital
1, 2, 3.
Congenital cataract can be seen, which can be associated with
Okay.
galactosemia.
Then yes.
Sir, in case of Wilson disease, Kaiser-Fisher ring can be seen in the eye.
No,
But
common for our children here. Commoner than Wilson. Congenital galactosemia, cataract, yes.
CMV retinitis also can be seen.
Right. So varieties of chorioretinitis, whether it is CMV or whether it is herpes, etc. So chorioretinitis, whether it is toxo, so chorioretinitis. Any other thing? So cataract, chorioretinitis. Anything else? Allergy, they were going on saying. So embryotoxon, posterior embryotoxon, they're looking at that also. So eye examination for that, right?
Yes, sir.
So all these are features that can be there in an ocular examination. So that is why it is important, right? So ocular examination is one. Then anything else which can be clarified with the child in the ward. One very important point in history and that thing.
Sir, on
Doesn't
exam-
it give you a chance to see the stool firsthand?
Yes, I would like examine the diaper for stool and urine staining of the
Exactly.
diapers.
The stool, not just a diaper. You can ask him to collect the stool and keep also. If you're using a card can be used. But best thing is to see the stool, pictures of the stool or the stool itself,
Yes,
so that
sir.
you are convinced what they say is yellow is actually yellow, or their yellow is not your yellow. So very
Yes, sir.
often it is a problem there. So it makes a big difference whether it is actually pale all the time or there are actually some yellow stools coming in between, right? In
Yes, sir.
your investigations and differentials, right? So what is the panel of, has Gaurav joined us?
Sir, I
Not yet?
think message in the group that there is a network issue trying to connect, sir.
Okay, right. So what was the panel of investigation, the standard panel of investigation you want to go for this child?
Sir, I would first do a baseline CBC examination, urea, creatinine, and electrolytes, and full LFT profile, sir, where I will look for the TB, DB, total bilirubin, and direct bilirubin to look for the conjugated hyperbilirubinemia to confirm that it is a cholestatic picture.
Right.
I would like to do an AST, ALT, ALP, and GGT to look for how much is the AST elevation compared to the GGT and ALP elevation. AST, ALT elevation more than the GGT and ALP elevation indicate hepatitis, while
Okay.
ALP and GGT indicate a more of an obstructive profile.
Why is GGT so very significant of obstructive?
Sir, GGT is secreted by the biliary ductal epithelium. So in case of any biliary pathology, GGT will be elevated. And kids, because of increased bone activity, ALP by default will be mildly elevated. So GGT is more specific for biliary atresia. More than 250 is suspicious of biliary atresia, and more than 850 is confirmatory for biliary atresia. Sir.
Okay. Which other of these cholestatic disorders is GGT inordinately raised? Is it just biliary atresia or there's some others where it is inordinately raised?
In sir, bile duct plug syndrome, sir.
Bile acid excretion syndrome. Those are the ones where it is again inordinately raised. Okay. Come back to this. What else?
Look for albumin to know the liver function also, and this will also have a prognostic assessment for the anastomotic healing of our anastomosis during the Kasai procedure.
What else? Albumin, what else? What else gives you a better idea of synthetic functions?
Globulin, sir.
No, which is a common thing that we do to find synthetic functions of the liver.
INR, sir. Or
Yeah,
total
prothrombin time. You should not get stuck in these simple questions.
Okay,
Prothrombin time, isn't it? That is what we look at besides albumin. Extremely important thing. Why is it important? One is that you will correct it.
Yes, sir.
You will correct it. What's the other reason why you might want to do a prothrombin time? You might want to do some procedure.
Intraoperative bleeding.
Okay, you might want to do even a preoperative liver biopsy.
Liver biopsy also. Yes, sir.
So that is why you need to do that thing. There are two things that we look for in liver biopsy. One is this prothrombin time, whether it is normal or not. What's the other important practical thing which will sort of how safe it is to do a liver biopsy or not? percutaneous liver biopsy. Yes. Yeah,
And
ascites. Supraja has written ascites. So if there is ascites, then we are a little careful, wary of doing a liver biopsy because we know tamponade will not be there and you can have bleed even if procurement time is normal. So these are the two things
yes, sir.
about things, right? See, practical questions will be asked just to see whether you have how much of work you have done in the ward and how practically oriented you are. It carries a lot of weight if you are practically oriented rather than just blurting out theory. So remember these simple things which you have worked and learned in the ward. They carry a lot of weight.
Yes, sir.
Okay. Is Gaurav there? Right. How do we proceed further? So we do an LFT, we do a CBC. Would you do blood cultures? Would you do cultures?
So if the patient is not clinically septic or fever episodes are not there, I will not be inclined to do a blood culture at the moment.
Okay. What is the other common infection which can present as jaundice in children? Hepatitis, jaundice.
So CMV hepatitis can
No,
present as
that's fine. That besides that, another system infection.
urinary tract infection, sir.
Excellent, urinary tract infection. So don't forget urinary tract infection. They can also present as jaundice.
Sepsis.
Right. What are the investigations you do?
So next I would like to do an ultrasound of the abdomen, sir.
Right. Anything specific in the ultrasound?
Sir, in the ultrasound, I would like to look for the liver echo texture, sir, liver size. And I would look at the gallbladder if it is visible. I would like to do actually a fasting ultrasound after keeping the child for 4 hours to see the distended gallbladder if it is present or not, sir. I would like to look at the size of the gallbladder and gallbladder contractility. If the CBD is visible, I would like to know the diameter of the CBD. If the CBD is not visible, I would like to know about the triangular cord sign if it is.
In a child, 1 month old, 2 month old child, CBD will be difficult to visualize. And if they say also that they're visualizing, you are a little wary of taking that thing. Isn't it?
Okay, sir. And,
what is the other very important reason why we do an ultrasound? I'm
Rule
sure Sir Dr. Bagri also would want to know this.
Rule out a choledochal cyst.
Exactly. So that is the other very important thing. Besides all that you have said about the thing. And if you are going to mention about that, what sign, your triangular cord sign, yeah, you better know exactly how the radiologist sees that. It is like those APPD questions in hydronephrosis. Where is the APPD taken exactly? You have to know. Same way here, you must know where the triangular cord sign is sort of looked at. So where is it looked at?
It is looked at the porta hepatis, sir. Just under surface of liver.
No, that's not that. Where with respect to the vessels, yeah, there's someone has written there. Right portal vein.
Okay.
So that is where it is looked at. Okay.
Okay, sir.
Right. So you look at that gallbladder, you look at that in ultrasound. Next, what other investigations?
What other in the ultrasound? Little more on the ultrasound.
More on ultrasound. So I was asking.
First, will your gallbladder is seen or not seen generally? What happens?
Sir, if it is in a case of biliary atresia, even in a fasting ultrasound, the gallbladder will not be seen, sir.
So, what else can be seen in the ultrasound in a case of biliary atresia?
Sir,
Will you look at the
triangular cord
spleen?
sign.
Sir, I will look
spleen.
for
Will you look at the?
Yes, I will look for spleen.
Will you look at the disposition of the bowel? I'm giving you some hint.
Yes, in case of biliary atresia splenic syndrome, it can be associated with a malrotation. It can be associated with a preduodenal portal vein
All that, no? When you're saying
and
about
interrupted inferior vena cava also. If asplenia is there, I would look at these things also because it can
if
be
you know that, you must tell that in the exam. Then you get more points.
I'm sorry, sir.
Yes. The
And you do an X-ray chest and abdomen before.
I would also look for ascites also in the abdomen.
Yeah.
Yes.
and subcapsular blood flow in case of biliary arteries.
Why? Why is there subcapsular blood flow? Why is that increased?
Sir, reason I don't. The reason I'm not sure, sir.
Okay, fine. So that you must say, if you're going to mention that subcapsular blood flow, which is correct, you must also say why. Okay, right. Next, what are you going to do?
Sir, for completion sake, I would like to get a HIDA scan also, sir.
Acha, why for completion sake? In this particular child who has persistent jaundice, who is relatively well preserved according to the findings, so why do you want to do a HIDA scan? 3 months, no? The child is 3 months. How long are you going to wait now for surgery?
No, sir, I will not. In the meantime, I'll counsel the parents and prepare for surgery also for what I would like to get a
You
HIDA
must
scan.
convince the examiner as to why you want to do a HIDA scan. Why don't you do a liver biopsy then? Preoperative percutaneous liver. Gaurav has come. So we'll switch to Gaurav. Gaurav, are you ready?
Yes, sir.
Yeah, give us your investigations. He was
Yes, sir.
saying that we want to do an LFT, prothrombin time, ultrasound. So give us your investigations.
Yes, sir.
We'll switch to Gaurav. Yeah. Thanks, Ashwin.
Yes.
Hello.
Yeah.
So we will do liver functions test, PTINR, TBC, all the routine examinations will be done, sir.
Okay. What are those reports? Tell us and how you interpret them.
So basically in sir LFT we will look for increased level of
No, show us
direct.
the report. Show us the reports. You have the reports.
Sir, there is big report is there, sir. That's why it can't be downloaded.
Okay. Okay. So tell us if you have the values.
The direct bilirubin was raised along with ALT and GGT.
Okay.
And sir,
Prothrombin time.
PTINR was raised, sir. PT was more than 40 seconds and INR was 4 minutes, around 4.
Okay. Okay. Ultrasound.
In ultrasound, they only said that gallbladder is contracted with hepatomegaly and ascites,
Okay.
mild ascites.
Fine. So any other investigation you have? Fundoscopy have you done?
No, sir, we didn't did any funder examination.
You know what you have to see on fundoscopy. We discussed that when you were not there. You know that.
Yes, a cataract and spots are to be seen.
Okay. Fine. Okay. Right. So fundoscopy is not done, and these are the features. Do you want to do an echo? Does someone want to do an echo?
Yes, sir.
When would an echo help? In which cases? Maybe everyone we don't do, but some cases you might want to do an echo. In whom do we do an echo?
Algely
When you
syndrome.
suspect, when you suspect alagili, isn't it? You are looking
Yes,
at
sir.
pulmonary
Alagili syndrome.
stenosis,
Yes, sir.
etc. Okay, right. Fine. So come back to your case. So now how shall we proceed? What is your plan? Is your plan also HIDA scan like Ashwin's plan was?
Sir, as ultrasound was not so conclusive,
Ultrasound is
should-
hardly ever conclusive.
so we should go for HIDA scan or we can go for IOC.
No, you can't say we can do this, we can do
We
that.
should-
You are the treating physician. You must
We will go for
justify
I-
in this child, in this circumstance, what you will do. You can't give the
So we
option
will
to
go-
the examiner like that.
We will go for HIDA scan, sir.
So you will go for HIDA scan. Okay.
Yes.
So child has a INR of 4. You have admitted to the ward today. Tell me the things that you will do. so that you will do a HIDA scan. Child is 3 months, remember. Already we are 90 days old.
So first of all, as the PTINR is raised, we will stabilize this child by giving vitamin K and FFP.
Okay.
Then we will repeat the PTINR. If it's in the normal
So you are
limits,
going to give both. You will give both vitamin K and FFP, both. Or will you give one of them?
I will give one of them, sir.
Which?
I will basically first of all try to give sir vitamin K.
Okay. If it does not respond, then you'll add on the FFP.
Yes, sir.
Okay. When would you electively give FFP? In what circumstance?
Pardon, sir?
When would you give FFP? In what circumstance? You will not just give vitamin K. Are there any dangerous circumstance where you would rather give FFP?
So when we will see any skin changes over the body surface of the
Okay, if there are ecchymosis, because what are you afraid of?
ecchymosis is
Where are you? What bleed are you afraid of? Which bleed can kill the
esophageal
child? Intracranial bleed.
intracranial hemorrhage.
So that is where you don't wait for a vitamin K. If you have
Vitamin K.
ecchymosis, etc., and you have any features, you give the FFP. You don't want an intracranial bleed. You want the PT to normalize as soon as possible, isn't it? Okay. So what else? So you will give FFP. You will give vitamin K. Yes. You will. Are you going to start something else because you are planning for HIDA?
I will give phenobarbital for 5 days.
Acha, okay. So you'll start phenobarbital. So day 1, you are done all this.
Cloth
Now you will, after 5 days, you will do the HIDA.
cloth కాలిపోతుంది.
Okay. What is the use of HIDA? Why don't we just proceed to intracolangiogram?
నాకు ఇంకొక ఐడియా
Why
వచ్చింది.
wait for HIDA?
కింద కార్ ఉంది కదా, కార్ లో ఏసీ ఫ్యాన్ కొంచెం ఫాస్ట్
Already
వస్తుంది,
so
దాని
late,
దగ్గర పెడదాం
3 months.
ఫ్యాన్.
Why do
Sir,
you want to wait for HIDA?
So HIDA will confirm
దీని
if
నుంచి ఏం
there is
రావట్లేదు.
intrahepatic biliary atresia is present or not.
No,
It will
no,
not go
that
into
is a
the-
very, very
ఇప్పుడు మళ్ళీ ఇక్కడ
dangerous
అంతా
statement.
వచ్చింది.
If you say that, the examiner will pounce on you. HIDA never confirms biliary atresia. Never.
So it will
What is the
confirm
only
present-
use of HIDA?
This is the
What is
commonest
the only
mistake
use
they
of
do.
HIDA?
it will
The only use of
confirm the-
HIDA is if there is an excretion seen, then it will rule out a biliary atresia, if at all. There also there are queries, but it will never confirm biliary atresia. So
Mhm.
you must be ready with your answer.
Yes.
If someone asks you why HIDA, why HIDA? So if excretion is seen in the gut, then it sort of rules out biliary atresia. The other way around. Okay, right. Because they will ask you, if this child is 3 months, why do you want to wait for HIDA? Why don't we just go to intracolangiogram? So you must be able to justify that. Right. In a younger child, you might say, yes, we have time, we can do the intracolangiogram, we can do the HIDA scan. This child, you will have to justify. Or if there's fluctuating jaundice, doesn't look like a clear biliary atresia, you might say, yes, probably it might, there's fluctuating jaundice, it might be a hepatitic state or something else where there's intermittent secretion. So let us do HIDA that way. So you must be very clear why you want to do HIDA. Okay. Right. Do you want to do a preoperative liver biopsy in this child, or do you want to do something else? What's your plan?
Sir, I want to do a liver biopsy.
Acha, preoperative, not intraop, not paracholangiogram and liver biopsy. You want to do before?
Yes, sir.
Why? Why?
Sir, it will further help in diagnosis as it will confirm the changes that will be seen in the liver or liver.
Okay, so if you say that, you are not wrong. You are right that if you have a good hepatopathologist, pediatric pathologist there, they will tell you that all these things are seen. You'll get your diagnosis. You are not wrong, but you will know. You can do the same thing if you do a do a cholangiogram and proceed. You will straight know whether it is biliary atresia or not.
Yes, sir.
So why do you want to do a pre-op biopsy? Another 5-6 days will go. So you must be ready for that also. Then you must be ready. Already the child, it is so late, so probably I will just go ahead with the intracholangiography. If you had time, maybe you could have argued for a preoperative liver biopsy. Of course, if you are thinking of a hepatitic state, you have other clues to tell you this is cytomegalovirus or this or galactosemia or something else, then you might say that yes, liver biopsy is required in this to get a diagnosis. It looks like a medical cause. So you must be ready with an answer to justify why HIDA, why preoperative liver biopsy, before you move on to intraopulangiogram and proceed, right? Okay, so now let us say in the center we don't have these two things, so you have to proceed. So what is your preparation as you go to
Any
OT?
role for MRI?
Sir is asking, is there any role for MRI? Does
Yes,
it
sir.
help in diagnosis of biliary
Nowadays
atresia?
they are doing it, but due to the expensiveness of the MRI, it is not feasible. For,
Expense and all is not answered in academic performance. See, you cannot say expense and all.
but sir,
You
it
will
has a
answer in an
superior
exam.
accuracy. So it has a superior accuracy. We can do.
What additional information it may or may not give? You've done ultrasound, that's good enough. You really need an MRI. If
No,
at all
sir.
you need an MRI, in what way it may help?
So justify, practically you can tell from what you do, would you do or not? Because the question is directed to you. So you say that these can be the features in the MRI, but I will not do an MRI, I will proceed to this. Something like that. You have to justify and say. Okay. So that the examiner knows that you are aware what the findings are in an MRI, but given the circumstances, you are not in favor of doing that. That is acceptable. Okay. Yeah. Fine. So how do you prepare this child? We have reached the threshold of OT now. How do you prepare this child for OT? Vitamin K, FFP, prothrombin time normalized.
Vitamin
Everything
A,
else
D,
is
A, K
fine.
given. Vitamin K given. Pre-op antibiotics started.
Actually, you start a day before in the ward.
Yes, sir.
Okay. Okay.
Then we will do a look for the normal coagulation study.
Right. Corrected. Prothrombin corrected. Yeah.
Yes, sir. Then,
What
sir,
else
after
before you go to OT? What are the important things? Any child before you go to OT, any child before you go to OT, any surgery, don't you do something else to the parents?
the counseling and consent.
Yes. Counseling. So what counseling will you do? That is important. You must be ready with that. In this particular child, what is the counseling that you will do?
We will counsel them and we will tell them that there is chances of hepatic failure, and if it persists, then they have to be ready for the liver transplantation. And it may need a redo surgery later on also. We will tell them about the complications of surgery and further prognostic factors.
Dr. Simi is there. Dr. Simi,
Yes.
please ask
No,
him
I'm
about the
thinking.
surgery. He said about redo surgery, he will counsel and all. Please ask him.
Okay. So what is the first step that what is the incision that you will make and how will you proceed before that, before making the incision and all that? What you will assure that it is handy in the OT before you proceed for surgery of biliary atresia? Something you have to prepare in advance.
Cholangiography, ma'am. Cholangiography.
Yeah, so you should, what all things then you should have is a
Yes, sir.
dye,
Yes, sir.
contrast, as well
Dye,
as
dye
the
should, dye should
radiographers.
be there, sir. Yes, sir.
Okay. So how will you proceed? The HIDA is showing no aspiration. Okay.
Yes, sir.
Gallbladder is partially distended. It was shown in ultrasound. Then next.
Sir, ma'am, we will proceed for IOC.
Hmm.
Here
So
we
where will you mark the incision? How will you proceed? You do laparoscopically or open?
open, ma'am.
Okay. So where will you make the incision?
Ma'am, we will make the incision in right upper quadrant, extending towards midline.
Extending towards midline.
Yes, ma'am.
So you will cut the entire, make the entire incision, cut the muscles in the till that before you, before performing the POC, or somewhat less also.
Someone less can be done, ma'am.
So you mark the incision, and supposing on POC you find that it was just a plug, then unnecessarily a big incision is made. So you mark the incision and you generally open the middle 1/3 so that
Yes, ma'am.
you can perform the POC and get the finding, and then you can proceed whatever way. You can even increase it. Okay. So how will you do the POC?
Ma'am, first of all, we will take a purse string suture.
Hmm.
And after that, ma'am, we will make an incision in the gallbladder and angiocath will be pushed.
So first you make a purse string incision. Before that, don't you jot down your inspectory finding, how the gallbladder
ma'am.
is?
First of all, after opening, ma'am, we will see the gallbladder and liver, and we will jot down the findings. After that, ma'am, we will take a purse string suture and giving incision on gallbladder, and we will put an angiocath. And after that, ma'am, we will push a gastrographene diluted with 1:1 normal saline.
Supposing after you take the purse string and you find that there is a bile aspiration, you find bile.
So, ma'am, then it will, ma'am,
Then you can still go on with it. But if it is a white bile which is seen, or there's
ma'am,
hardly any bile, then you know that it is a case of pure biliary atresia, and you may not go
Atresia.
ahead with any POC.
Yes, ma'am.
If it is the gallbladder is totally atretic and there's white, then you may not go ahead with it. But in case there is some yellowish bile that you are seeing, then you go ahead with and to see delineate the anatomy. Okay.
Okay.
What next? You have taken a purse string and then you have put the catheter and all that. So what next?
Then, ma'am, we will put the dye.
Put the dye. Before that, where will you place the plates? And how will you increase the sensitivity of this test? That you want a good outcome and no artifacts. Generally, it is advised that you put sutures rather than putting the towel clip, because they can later on overshadow the area that you were interested in. So when you put the towels, you just fix them up with the sutures, silk suture, and then go ahead with the performance of the POC. Okay. Now you have put the dye. Next,
Yes,
one
ma'am.
shot is taken. Okay. There is a good flow. supposing you find now there was a little bile which was aspirated, you wanted to perform the POC, you perform the POC and there's a good distal flow. What next?
Then ma'am, we will clamp the distal common bile duct to look for the intrahepatic ducts.
Why?
Because ma'am, any patent proximal ducts may initially fail to opacify with contrast material.
No, the CBD is seen. You put through the CBD is seen. But still you will go ahead with the clamping of the distal CBD?
No ma'am. No ma'am.
Why not?
Then we
Can't there be a correctable type of biliary atresia? Haven't you heard? That is why both these steps are essential for POC. Then you clamp, and what else you do? You also lower the head end so that you can see the proximal ducts. Okay?
yes ma'am.
Both these steps are important. And
These are
sometimes
practical steps. You must remember them and you must say them. Only then they will have an idea that yes, you have seen this in OT.
okay, these are very,
Yes, ma'am.
very important things. And your entire viva can be on POC. You sometimes get a exam question also on POC. And sometimes you get a what are the various conditions which can mimic biliary atresia? One is neonatal hepatitis. So in neonatal hepatitis, what do you expect? Once you will clamp the CBD, you clamp the CBD with what? With what
Bulldog.
instrument? Yeah. So you have now lowered the head. So in neonatal hepatitis, what do you expect with cholangiogram? The proximal ones, that's how they will be.
They will be dilated.
So they will be well formed, but they'll be dilated. Okay. What about the
Yes ma'am.
plug syndrome?
Ma'am, it will by giving the pressure, ma'am, the insipited bile will go
So
down if there
proximal
is
duct
patent.
will be okay. So these are the DDs of this thing. What about choledochal? That also you can find out. For that, proximally, yes, you will see what is the extent of dilatation. So one is neonatal choledochal cyst, one is biliary bile plug syndrome, one is neonatal hepatitis. What else are in the DD? Have you heard of her term biliary hypoplasia?
Yes ma'am.
So how will the proximal ducts be?
Ma'am, it will be contracted.
They will be not well formed. We have
Not
seen
well
one
formed.
patient. We have seen one patient like that. And then we had put him on a big long-term UDCA therapy, and the patient has done very well. So these
how
are the
is
various forms. That is why both components of POC are important. Okay?
Yes,
Okay,
ma'am.
Dr. Kanishka, you take over.
Yeah. Gaurav, how is the diagnosis of, we have taken you to biliary hypoplasia. How is the diagnosis of biliary hypoplasia established?
You are asking me?
No, I am asking Gaurav.
Acha, acha.
Gaurav,
Okay.
Yes, sir.
how is the diagnosis of biliary hypoplasia established? It is not,
On liver
it is beyond
on liver
the
biopsy, sir.
cholangiogram.
On
Huh?
liver biopsy.
On liver biopsy. And you know what we look for in liver biopsy? You are right. What do we look for in liver biopsy?
Giant cells.
Giant cells? No, that is hepatitis. Biliary hypoplasia, you are saying, no, that means the interlobular bile ducts are less. They're not
Ductal
there in
portal
the
ratio.
portal tract. BDPT ratio. Bile duct to portal tract ratio, less than 0.5. Okay, come back to this child. So you have done a cholangiogram, you find that there is no flow or nothing going up. Whatever is going down, nothing is going up despite your clamping, etc. And then you will proceed to do Kasai's, right? So just tell us, we will finish with this. Tell us the basic steps of the Kasai procedure. Basic operative steps.
The first of all, sir, we will take out liver out from the abdomen by
Okay.
ligating and cutting the ligaments.
Okay. Go ahead.
Then, sir,
Go ahead. Left, right. Yeah, you must go one after the other. Don't stop. If you stop, the examiner will ask you unnecessary question. So go with the flow.
after the peritoneum lining the hepatoduodenal ligament is open to identify the structures in that area. Then, sir,
So in this peritoneum that you are opening, generally what do you find in biliary atresia?
fibrous remnant.
Okay, and you find a lot of lymphatics there. So wherever
Lymphatic.
you open, you find ooze coming out. Bile stained ooze. Okay, fine. Then
Yes, sir, we will take care to avoid injury to aberrant vessels, hepatic arteries nearby.
you must tell me the steps like you have seen. Have you seen biliary atresia
Yes, sir.
surgery?
Yes, sir.
So you must tell me accordingly. So you have opened the, you have got the gallbladder in your hand. I will start it off for you. From the gallbladder, you dissect it off the bed. That will lead you to the atretic biliary tree. You try to separate the atretic biliary tree to the porta. And when you reach the porta, you have to identify the vessels and sling them.
Yes, sir.
So which are the vessels you identify and sling?
So basically, we identify cystic artery.
Cystic artery is one small artery which, as it is, the gallbladder is so small, it is hardly existent. Okay, we will ask one of your friends to help. Dr. Ashwin, you are around? Dr. Ashwin, will you just recapitulate for us the steps?
Yes, sir.
Yeah.
So after opening the abdomen, you look for.
Yeah, we have reached the porta. You tell us from there onwards.
So the extent of dissection will be that you have to identify up to the right hepatic artery and lower inferiorly up to the portal vein and superiorly up to the Glissen's capsule, sir. And the portal.
That is right, but what are you going to sling? Operative steps is practical operative steps. We have dissected the gallbladder out. We have reached till the remnant of the porta. We've got it in our hand there. Now, which are the vessels that you are going to dissect and sling? Identify, dissect, and sling.
Hepatic artery and the portal veins.
Okay, the branches, the right and the left.
Right hepatic
and
artery
the
and the
stop.
portal.
Everything you will identify and you will sling the right and the left.
Yes, sir.
Okay. After you've done that, then?
Small vessels of the portal vein should be dissected and ligated off. We should not use cautery here.
Where? Small vessel from which part of the portal vein? To which part of the liver?
To the portal plate, sir.
Correct. So from the Y of the portal vein, where it bifurcates, from there small branches go towards the porta, and they are the ones which can create trouble. So they must be individually ligated or buzzed, whatever. But they must be taken. Only then can you depress the portal bifurcation to reach the portal plate.
Yes, sir.
Isn't it? Because
Yes,
you have
sir.
to see the posterior edge of the portal plate. You're going to take bites there when you do your portentrostomy. So then,
Yes,
what about portal plate dissection?
The portal plate should be incised with a sharp knife.
Okay, you've got that thing in your hand, the gallbladder and that thing. From there, you proceed. How is this dissection done?
A sharp dissection, sir.
Yeah, but how? Perpendicular to the surface of the liver?
Perpendicular to the liver surface, sir.
Oh, then you will go into the liver if you go perpendicular to the liver surface. See, we were looking for those words that you will go parallel to the liver surface and that you will not go into the liver. You just want to bear the Glisson's capsule so that those little ductules open up, and you don't want a whole lot of bleeding, and you will control the bleeding with compression rather than
Got
cautery.
compression. Got
And
compression.
all these things are what the examiner wants to hear from you. And what is the extent of your dissection? That is the next question.
Sir, in Kasai, we extend the up to the right hepatic artery on the one side and below the portal vein, and other side up to the where the umbilical vein joins the left portal vein, sir, into the rex recess.
Yeah, your answer for the left side is correct. You are going into the rex recess there. So the first bifurcation on the left side. Similarly, the first bifurcation on the right side in your extended, whatever you are seeing. So those points must be thing. And why are those points important? Why are those areas important? Those limits? Because that is where the right and the left hepatic ducts come.
Origin of the
So you will
ductules.
find the remnants there. Yeah, your chance that you will encounter bile flow are maximum if you've gone till those.
Yes, sir.
Right. Okay, then. So your plate is done. You
Then-
have packed it. Some little
Yeah.
ooze is there. You have packed it.
Started
Now,
with a gauze sir. Then we take the Roux-en-Y anastomosis, sir. 10 centimeter distal to the DJ
so
flexure,
kindly return the liver back
liver back into the
as
abdomen.
you do the thing. Yes, that's also important. You can't be having the IVC kinked there. So these little things tell the examiner that you know practically what you should do for a safe surgery. Okay.
Yes.
Right. Go ahead.
10 centimeter distal to the DJ flexure, small bowel is divided.
Why are you telling 10 so very emphatically 10? Why not 15? Basically, what's the principle? You leave one long lazy loop free from the DJ.
Okay, sir.
So one long lazy loop you leave, and then it may be 10, 15 something, and then you see the arcade and then you divide it, isn't it?
Yes, sir.
That is technically the principle, so that you'll have a convenient vascular limb going up. Right.
And the Roux limb length is 40 centimeter taken, sir. And the ends are
If
sewed
you're
on
doing
the
40, you say 40. People who do 20 will say 20, and they will answer their questions accordingly. So if you take 40, the only problem is you will go very much lower down. So many of us take much shorter lengths. So you can say whatever you do at your center, no problem. Right.
the ends of the Roux limb is sewed off, and the end to from the portas to the side of the Roux limb, porta enterostomy is done, sir. We do in our center, we use intermittent sutures on this, sir.
Okay, interrupted sutures.
And
Fine.
and the jejunocleidostomy is completed end to side, sir. And the
Right.
Roux limb is taken in a retrocolic fashion. So after finishing the anastomosis, the mesenteric defect also is closed.
Okay. It's taken to the right of the middle colic to the left of the middle colic.
Sir, usually it is taken right, sir, but based on the anatomy of the middle colic vessel, we will find a convenient windows.
Okay, it's always taken to the right. Yeah, you are right. Correct. Why? Because that is where you find the best space, and that you don't have a kink. If you take it to the left, you can have a kink. So it
Okay,
is
sir.
taken to the right, and you have a good window there. Okay, right. After that, are you going to leave a drain? You will not leave a drain.
Sir, both has advantages and disadvantages, sir. Leaving a drain will help in wound healing, and undue, especially in case of ascites, it can affect the wound healing, undue pressure on the wound. But if you leave a drain, that can lead to protein loss and continuous oozing, continuous
right.
leak of fluid from the drain side, sir.
Oh, fine. Right. Post-op, child is fine, has recovered. How will you prognosticate and counsel this particular child? How will you prognosticate and counsel? Intra-op, you have not had much of bile
So
flow,
this kid
even
is
with an extended
this
dissection.
kid has presented within 2 months time, which is less than 16 days, 60 days duration, which is a good prognostic factor.
3 months. Child is 3 months, I thought.
2 months. I'm sorry, sir. Yes, sir.
Child is 3 months.
Okay, sir. If it is less than 60 days, it is usually good prognosis, sir. Then if introp at the doing the portoenterostomy, if you can see bile coming out, then it is again a good prognosis, sir.
Okay, we have not got that. Bile.
Depending upon the surgical technique and type of dissection also will help in prognostication of the further prognostication of the disease, sir.
No, you must be very clear. You know, prognosis of biliary atresia is a standard question that you will be asked in viva, in theory, everywhere. So pre-op factors, intra-op factors,
Yes.
post-op factors, you must be very clear.
And
Then hardcore factors you must say, and not iffy ones. So don't talk about technique and this thing. You've mentioned some pre-op factors, age you mentioned. There are other things are not very clear in the pre-op this thing. Bilirubin is of course a high this thing. Then now you come to intra-op factors. You mentioned there is no flow, very significant. There is some ascites in this child. The liver was rounded, so probably there is some cirrhotic changes already which have come in there, late changes. So all these are negative prognostic factors, some portal hypertension during a dissection. And now you have come to post-op factors. So what are the things in post-op
the
factors?
liver biopsy showing the ductule size less than 150 micrograms, 150 micrometer
Okay.
micrometers.
So liver biopsy is one. We'll come to that. What are the others?
Once a patient starts passing stools, the
So whether you get
intermittent
colic
passing of
stools or not.
interpassing of greenish yellow stools will prognostic.
So that's the other thing. Another one in the next few months.
Falling of the bilirubin levels, sir.
Okay, yes, episodes of cholangitis. So you must quickly list them one after the other so that they know that you are aware of it. Then they will interrupt you saying, okay, fine, we go ahead. Right. So now to finish, can you just list the histological prognostic factors as we know currently? There's a lot of controversy there. We all know. So just list them 1, 2, 3, 4. We will wind up with that.
So one is a bile ductule size, sir.
Okay. Why don't you start with the most important one? Why do you start with the iffy ones? What is very, very important? Which has little doubt?
So I'm not sure.
Fibrosis.
Okay.
Fibrosis score. That is probably the most important thing. That directly tells you whether it's progressed to cirrhosis and irreversible liver damage or not. So that's probably the most important. Then next. So Ishaq score or whichever score you want to say, but fibrosis extent. Another thing then about your ductule size.
Presence of
You were saying 150. Yeah, some people say 150, some people say 90, some 200. You can justify that. Again, that is one point. Another one, third one.
presence of giant cells.
Okay, if there is an element also of giant cell, is it good or bad? Giant cell.
Bad, sir.
Bad. Okay. Then
Periportal inflammation and fibrosis. Bile plugging.
fibrosis we've already talked about. Fibrosis. That's there. Okay, inflammation is another iffy thing. Yes. Okay, then. Are there some infections which are bad, which are known to coexist with biliary atresia? The prognosis correspondingly is poor.
So CMV hepatitis and
CMV. Yeah, typically CMV.
It causes mononuclear infiltration.
Yeah, so CMV typically it can happen in up to 30%, and that is not a great thing to have. Prognosis becomes poorer. Okay, something else, some embryonic features which again have some questionable bad significance. Ductal plate malformations being there. Again, that tells you that it's a very early event and probably prognostically poor. So all these things are there, but you start with the most important thing, which is the fibrosis score.
Yes, sir.
Okay. Dr. Simi, sir, we'll wind up here.
Yes, if they can tell something about cholangitis. How to
Yes.
post-op cholangitis.
There's a question, how do you manage post-op cholangitis? I think we'll come back to Gaurav. Gaurav, we will finish with you. Post-op cholangitis, how will you manage? Immediate post-op, let's say for 5-6 days, hectic fever and child is sick. How do you manage? Gaurav. Post-op day 5, you have some bile stools, colic stools coming and child has hectic fever. Bowel sounds are there. You don't think it looks like a leak. You think it looks like cholangitis. So how do you manage? We are not able to hear you, Gaurav. I think you are muted.
Hello.
Yes, now we are hearing you. Say.
Yes, sir. So we will give course of antibiotics, broad spectrum antibiotics.
Say, go on, don't stop. What is your idea of broad spectrum antibiotic? You must say, this is antibiotic, this generation, I will give in this dose to cover this, like that you must.
Third stage cephalosporin, sir.
Okay. That, yeah, you may even give an aminoglycoside. You will also give, you already are probably giving metronidazole. So you will say that you will give antibiotics, IV antibiotics, update them. What else?
Then, sir, we will give steroids.
Dr. Simi will ask you about steroids.
Yeah, what?
Why don't you
What
say more
what
common
is-
things?
Yeah. Especially, what is the difference between the steroid dose that you give for HIDA and what you give for cholangitis?
Ma'am,
Is
for
there difference of
2 mg per kg per day, sir, ma'am, for cholangitis. Hello.
that may be a little less when you give pulse therapy? Okay, we can take it. It is on the lower side, 2 to 4.
So
Then-
steroids is a double-edged sword, but it's okay. Your answer is not wrong. But I think you should first say IV support, good inotropes, plasma, whatever, FFP, etc. Correct the
And
parameters.
antibiotics. Antibiotics
Yes,
you
say
have
these
forgotten.
first, and then go on to other.
Sir,
Okay, who is the one who gets cholangitis? Is it the one who secretes bile or someone who doesn't secrete bile? Gaurav? Who gets cholangitis? Someone who has colic stool or someone who has acolic stools?
sir, who has a colic stool?
Colic
No.
stool.
Someone who is secreting is the one who is more likely to get cholangitis. So remember that. Okay. Yeah. Fine.
Okay. I think we can wind off now.
Yes.
Can I ask one last question?
Yeah, sure, sir.
See, Dr. Simi was asking you about operative cholangiogram. So when the dye is going into the intestine and the gallbladder is there. So can you do what is called a gallbladder Kasai? Have you heard of it?
No, sir.
What is gallbladder Kasai? If you're getting yellow bile, operative cholangiogram, the dye is going only up. No, the lower CBD is not patent. The CBD is blocked. So you can just anastomose because gallbladder has got the bile is coming up to the gallbladder. You can just anastomose the gallbladder to the true and while loop.
Yes, sir. I said that if it is white bile, then you need not do. I see yellow, then they should still go in for it.
Just like that, some examiner may ask you a question. It's not very popular, but once in a while, gallbladder kasai it's called. Okay. Right.
So Gaurav, your performance is borderline.
Average.
Yeah, you must read and you must learn to say the standard things and the simple things, the basic things as it comes. Right?
Yes, sir.
So that is homework for you. We will come back again to have another presentation by you later. So we will leave you as borderline. Okay.
Okay.
Chalo. Thank you.
Thank you.
Thank you. All
Thank
the
you.
best.
Thank you.